is, how quickly can I get back into whatever it was they were doing? And, what we found is that, their recovery rate is that much quicker. Their need for intensive rehabilitation is somewhat reduced because we're keeping all of those things in place. You had a question? Yeah.
I refer quite a few people out for endoscopic procedures. And how many people are you doing discograms on prior to doing the procedures? Do you find that that's something that should be done all the time?
Yeah, I do. Before I operate on any patient, whether it's just a decompression or a fusion, I will routinely carry out a discogram, and the reason that I do that is, the post-discographic CT really allows me to have a look inside that disc in a more sophisticated way than if I didn't do it. And so when I'm using the endoscope, I'm able to then go down and, where you position the endoscope in the disc space is dictated by where, the pain-producing pathology is. So whether you come in, at a 60-degree angle or more laterally will be affected by what you see with the post-discographic CT.
Are you doing any coring on the foramen or in the spine, anybody that has stenosis?
Yes, yeah. I mean, whether you use an in-out technique or an out-in technique, will depend again upon, the system that you're using and the particular pathology that you're dealing with. But the foraminal decompression, the tools now that we can insert through the endoscope, there's rasps, there's burrs, there's drills. So, what's happening now actually with the endoscopic approach is that not so much intradiscal work is being done, because people are saying, well, listen, that's not really where the problem is. We have to move ourselves into the foramen and into the decompression of these neural structures without taking out too much of the discal components.
Last question. When I'm referring people out for epidurals,
Yeah.
and normally when you guys get these approved, you're getting them approved, the approved as free, right?
Yeah.
The question I have is, why, and I've never understood this, you really don't know sometimes whether the pain's setogenic or dystogenic.
Right.
Okay? If you're given 3 shots in one area or the other, why wouldn't you give one in one area, see if there's relief, and one in another area, instead of popping 3 in one zone and then 3 in another?
You're right. You're right. You're right. I agree with you. I think that, that kind of is a point that goes towards, more thought being given to accurate diagnosis beforehand. And I think that, with all of these surgical techniques, how wonderful, they all may seem and how non-invasive, more attention exactly has to be sort of focused on the initial correct diagnosis. So if you are giving, like a series of 3 epidurals, you're right, it doesn't really make any sense. The argument that was used before was that, well, maybe we didn't get the medicine into the right place. But that was an argument that came about before the routine use of fluoroscopy. So if you're using fluoroscopy and you're competent and you're doing the procedure correctly and you've got the medicine in the right place, then if it doesn't work, it doesn't work. Move to another potential pain generator.
I'm amazed when I look at your slides. When I think of advanced arthritis or stenosis or anything that's been there a long time, I'm amazed you can actually decompress it and get the result you're looking for. Do you have a screening procedure ahead of time when you look at a patient and just say, hey, this is not going to be compressed?
Well, when you say decompress, you mean indirectly decompress or directly decompress?
Well, the shaper, is that what decompresses it?
Yeah, the indirect decompression. Well, if there is if the canal is significantly stenosed, both centrally and peripherally, then the indirect decompression may address the peripheral component, and it does. And you can see, I mean, it recreates that height, so you can see the changes that's going on. It's the central issue. So usually if I've got a significant central stenosis, then what I will do is if it's a 5-1 disc that I'm treating, I'll go down posteriorly with the retractor system, one of the minimally invasive retractor systems, and I'll carry out a minimally invasive direct decompression, and I'll access the disc space that way. If it's a 4-5 disc or it's higher, then I'll use the posterolateral approach for the interbody, but I'll go down again posteriorly for the bonian ligament and flavin decompression.
You're pretty much saying that just about everything will open up properly.
Yeah.
Given the approach.
Yeah. Well, no, what I was saying is if it's a central stenosis, it's a significant central stenosis, then I will decompress that directly. But I'll use a minimally invasive approach for that.
You mentioned very often the decompression of the disc, the narrowing of the disc, causes slippage.
Yeah.
As you heighten the disc space, it straightens itself right out.
Yeah. There's.
That will take away the shear force on it.
Yeah. Yeah, well, with a spondylolisthesis, there is like this auto correction that goes on, because as soon as we get into the disc space with those sheaths, there's a slippage back. So yeah.
What percentage would you say you're doing fusion versus the disc activity?
What percentage of my practice? Or, I mean, I'd say, in my practice about, 3 to 5% of my patients end up having, back surgery, and of that 3 to 5%, let's say about 65 to 70% are just discectomies. The rest of those are fusions.
What's the likelihood of they coming back to return for the fusion later?
Well, it's, the likelihood compared to an open approach is significantly less. I mean, with the cases that I've been doing, and I've been using the endoscope since 2003, 2004, I don't have exact numbers, but I'd say a very low number, very low amount of those patients end up coming back for, interbody fusions.
What's the recovery time for a patient to be able to go back to work on average?
Well, with a fusion, yeah. Again, depending upon, obviously their occupation, but if they're involved in a sedentary or non-manual position, 4 to 6 weeks, sometimes even sooner.
I'm going to ask you one that you may be a little uncomfortable with, but when you look at your colleagues out there,
Yeah.
what are you most critical of when you see what they're doing, that you'd like to see them change, whether you can impact that change or not? What are you dissatisfied seeing out there?
Well, I think overall, is what I was saying before about the issue of diagnosis. I think that if more time and more resources are spent to accurately diagnosing where the pain is coming from and what the actual problem is, before we kind of like dive in and carry out the surgical procedure. So I think that, when I've gone to national, international meetings, I'm always standing up saying, look, we should be focusing more on diagnostic techniques and working out really who the best patients are for surgical intervention, because, you may have the best surgical procedure, but if you continuously pick the wrong patient, your outcomes are just going to be, less than optimal, and we're doing a disservice, I think, to patients.
When you're doing these fusions, do you preserve the anterior longitudinal ligaments?
Yes, yeah, that is, I've never gone through it inadvertently, but, it's preserved, and so I go, as close to it as, radiologically possible, and by preserving that, and once that has been, once the device is in place, it's, the tautness in that is kind of like, it's re-established. And with, as I say, with A-lifts, the fact, obviously, of the issue of visceral and vascular injury, that's being taken down as well. And, again, that was, it's kind of like it's another element of disregard for these paraspinal structures, which is, which is one of the reasons why the total disc market hasn't really worked out either, because there was such a destabilization of these structures that, you know, you could put in this motion-sparing device, but it, you know, everything, you know, you essentially destabilized the back because of all of these elements were taken away. So anyway, any more questions? All right, guys. Well, yeah. No, actually, you know, I mean, you know, nerves are pretty resilient structures. You know, you know, the identification or the recognition that this is the problem and the decompression of it. I mean, once I've decompressed the nerve, you know, the patient, you know, in recovery, they're noting, you know, a significant change. So what I've found over the years with regard to this issue of permanent nerve injury is that it's not as permanent as, you know, maybe we think or maybe sometimes we communicate to patients. You know, nerves do regenerate, and sometimes it takes a few months for that to come back. But, you know, I found that decompressing it, you know, generally leads to, you know, a return of function. Yeah. So how many of you would like, you know, have an MIS approach if you needed one? I mean, would you guys, if you needed back surgery, would you